Assalamu alaikum wa rahmatullah. Today we will continue our talk on the rhythmical excitation of the heart. So in the last lecture we discussed how the SA node generates the electrical action potential. Okay, and that's why we call the sinus node, sinoatrial node, as the pacemaker of the heart. And we discussed the mechanism of firing or generating these impulses. So then this impulse should pass through both atrii, okay? And this should happen very fast. And as we said, the action potential can travel all over the atrial muscle cells because they are connected and they work as a syncytium. However, there are more or faster routes for the action potential to travel through or across the atrii, okay, and between the right atrium and the left atrium. And this route, the first one that connects the sinus node actually with the left atrium is part of the internodal pathways. And there are fibers that connect the sinus node or the sinoatrial node, okay, all over the right atrium, until it reaches the AV node, okay, which is another node. It has the ability to generate an action potential, but this does not normally happen. We will discuss later why. That's why the pacemaker is for the heart is the sinus or the sinoatrial node and not the AV node. However, it works as a connecting point between the atrium and the ventricle. The action potential should pass through this node, and there will be a delay during this passage. Okay, this delay actually is good or is actually relevant to make the ventricle contract after a while, okay, from the atrial contraction. The velocity of conduction in the atrial muscle is about 0.3 meter per second, okay? But in the internodal pathways that we talked about, it's faster. It's about 1 meter per second. We have an anterior interatrial band, okay? This passes through the anterior wall of the atrium to the left atrium, okay? And also we have the 3 other branches, okay? And they terminate, they end at the AV node, and these branches are called anterior, middle, and posterior, okay? Anterior, middle, and posterior internodal pathways. So these pathways function as a faster route for action potential transmission from the SA node into the 2 atrii and then finally into the AV node. So this actually, if we want to measure the time lapse between the action potential generation in the SA node and reaching AV node, it takes about 0.03 seconds. So the delay from the SA node into the AV node to reach the AV node is only 0.03 seconds, which is considerably fast. And so this is another view for the internodal pathways connecting or connected to the AV node. And then we can see that after AV node, there is fibers that penetrate the fibrous tissue between the atrium and the ventricle, okay? these fibers are called penetrating portion of AV bundle. And then we will have a segment of the conductive fibers called the AV bundle, which is the distal portion, which branches into two branchings, the right bundle branch and the left bundle branch inside the ventricular septum. So in the AV node, okay, when the impulse reaches the AV node, there will be a considerably slow conduction of the signal, and that makes a delay of about 0.09 second. Okay, so there will be a delay for the signal before it reaches the ventricle in the AV node of about 0.09 second, and also there is further delay in the penetrating portion of the AV bundle. Okay, and this is about 0.04 second. So in order for the signal to reach the ventricle, there is a delay of about 0.12, okay, 0.12 second together, or we add this up into the 0.03, okay, that required the signal to move from the SA node into the AV node. So if we added up the 0.03 with the 0.012, okay, we will have about 0.05 or 0.06, okay? It's about 0.16, sorry. It's about 0.16 delay from the SA node, the generation place of electrical signal or impulse generation into or crossing into the ventricle. So to cross the ventricle, to cross the atrium into the ventricle, to reach the ventricle, it requires the impulse or the time lapse for the impulse to reach the ventricle is 0.16, and this is a delay from the place of generation of impulse generation to reach the ventricular muscle. Okay, so yes, if we added up 0.03 with 0.09 with 0.04, it's 0.16. After reaching the AV and the delay that occurred, we will see that the signal will travel into the AV bundle, okay, the right and left branch of the AV bundle, which actually passes from the AV node, okay, into the ventricle. Okay, of course, طبعا this conduction is considered very fast, the Purkinje system, okay, اللي هو starts from the AV node or after the AV node and passes through the AV bundles, the AV right and left branch, and into the whole cardiac wall. So the signal is considered to be conducted very fast, except for the part of the AV bundle that is called the penetrating. Okay, this one, the conduction is slow. Okay, they are very large fibers, okay, and even larger than the ventricular muscle fibers, but their function is not to contract. Their function is to transmit the action potential very fast, and the velocity is about 1.5 to 4 meters per second, and that is a velocity that is higher, 6 times higher than the usual ventricular muscle velocity or conduction, velocity of conduction. And also it is 150 times that in the AV node, because we knew know that the AV node is very slow. The conduction is very slow. So it's way faster than the AV node conduction. And this fast conduction in the Purkinje system allows almost instantaneous transmission through the entire ventricular muscle. Okay, so this fast transmission allow the impulses to be transmitted to the whole ventricular walls, okay, very fast. And what is the cause of the rapid transmission? Okay, the cause of rapid transmission is the high level of permeability, okay, which is done by the gap junctions that are present between or at the intercalated disc between the cells, which makes the Purkinje fibers. And also the contractile myofibers are very few because it's not their function to contract, and that makes it even faster. The conduction in the AV bundle is a one-way conduction. And that means it doesn't allow a backward transmission of the signal back to the atrium. So the signal moves from the atrium to the ventricle and is not allowed to go back into the atrium. Okay, so it prevents the re-entry of cardiac impulses. And this actually allows only forward conduction from the atrium into the ventricle. Now, the atrial muscle, we know that it is separated from the ventricle. So we know that the atrium is completely like an isolated syncytium, okay? And the ventricles are also another isolated syncytium. But except in the AV bundle, okay? In the AV bundle, الأتريال muscle بتكون connected, or there is a connection between the atrium and ventricle. So except for this route, there is no connection or electrical connection between the atrium and ventricle. So that's why the ventricle cannot transmit the same signal back to the atrium. And we know that the AV does not allow backward movement. So that's why there will be no re-entry of the signal back to the atrium. Okay. And we know that the reason for the isolation between atrium and ventricle, the electrical isolation, is the presence of a continuous fibrous barrier, which works as an insulator, which prevents the signal movement or the impulse to move backward. Okay, or even from the atrium to the ventricle, except for the, of course, the AV node and AV bundle. Sometimes in abnormal conditions, there might be a muscle bridge, okay, that might make a route or another route for the impulses, which makes the impulse able to travel backward from the ventricle. When it reaches the ventricle, it can travel backward into the atrium, and this actually will cause serious cardiac arrhythmias because it will make the atrium to contract in a time where it should be relaxed, okay, and it will make a lot of abnormalities in the rhythm of the heart, and that could be very serious. Now, if we want to look at the distribution of the Purkinje fibers in the ventricle, we can see that there is a left and right bundle branches, okay, as you can see here, and they actually passes downward after the AV node and the penetrating portion, they passes downward inside the septum toward the apex of the heart. So the heart has a base, which is this, and an apex. So if we look at the heart as a pyramid, so it has a base, okay, in the let's say the top, and an apex in the bottom. So these bundles divide into left and right, and they actually lie just beneath the endocardium, okay, into the either the right or the left side of the ventricular septum. And after that, they even branch more, okay, they branch into smaller branches progressively surrounding the walls of the heart. Okay, after they reach the apex, they branch in smaller branches, and then the smaller Purkinje fibers, they can penetrate 1/3 way into the muscle mass, and then they get continuous with the cardiac muscle fibers. Okay, so then the cardiac muscle fibers will continue the transmission of the signal. If we want to measure the delay of a signal that passes through the Purkinje system, it only requires 0.03 seconds, okay, from the time that the impulse enters the AV branches to reach the whole طبعا terminations أو ends of the Purkinje fibers. So it only requires 0.03. So here we see the delay is about 0.16, okay, 0.16. And then when it passes through the Purkinje system, it's only about 0.19. So only 0.03 delay between this point and this point. So this is considered very fast and instant transmission of the signal. Now the signal should transmit through the cardiac muscle wall or the ventricular muscle wall. After reaching the end of the Purkinje fibers, the impulse should be transmitted through the same ventricular muscle fibers. نفس الفibers, now they will conduct these signals. The velocity of transmission now in these ventricular fibers is about 0.3 to 0.5 meter per second, which is 1/6 of the Purkinje fibers. So it's less speedy, or it's slower than the Purkinje fiber, the conduction Purkinje fiber. And the pattern of transmission of the cardiac impulses in the muscle is actually a little bit different, because the cardiac muscle, they wrap around the heart in a double spiral way. So if you look at the anatomy of the layers of the muscles of the heart, they are wrapped in a spiral way, in such a way that they make like a 2-layer or double layer that are spiral in direction, and they are separated by a connective fibrous layer. So that angulation of the fibers layers requires another 0.03 delay, 0.03 second delay, until the whole muscle layers are have the signal conducted. Okay, so then we can add up the delay that happens in the Purkinje system, which is 0.03, to the delay that happens in the cardiac muscle, spiral cardiac muscle layers, which about another 0.03, and this makes a total time of transmission of 0.06. Okay, from the initial bundle, right, left, until it reaches the whole ventricular muscle fibers with the whole, let's say, whole fibers, or the whole layers of muscle fibers, which is about 0.06 seconds. Now let's talk about the control of excitation and conduction in the heart. What controls the heart rhythm, and what controls the work of the pacemakers? So we talked before about the pacemaker of the heart, and that was actually the sinoatrial node. So why do we consider, or how did we figure out that the SA node is the pacemaker of the heart? Actually, there are three places that have the autorhythmic capability, which is the atrial sinus node, the AV node, and the Purkinje fibers. So three places that have the capability to generate action potential and to have an autorhythmic activity. But the point here is that the AV node, okay, can have a self-excitation of 40 to 60, okay, times per minute. And this is the frequency of self-excitation. It can have 40 to 60 self-excitation or action potential per minute. So the Purkinje fiber is even slower. It has the capacity to generate 15 to 14, okay, time per minute. However, in the SA node, the self-excitability is actually the frequency of self-excitability is about 70 to 80 times per minute, and that's the heart rate. That's what we know about the heart rate. The heart rate is about 70 to 80 heartbeats per minute, and that's actually is parallel to the self-excitatory rhythm of the SA node. So why is then the atrial sinus node is the one that makes the pace, or that is considered the pacemaker? Actually, the question is very simple and very straightforward. It's very clear that it is faster than the other two. Okay, it's the fastest for generating the action potential. So that's why it controls the rhythmicity of the heart, because the discharge rate of impulses is fast. So whenever it discharges the first, let's say, impulse, it's gonna reach the AV node, okay, before its self-excitatory impulse starts. So it will only conduct the impulse that reached it from the SA node, okay? And even when it's time to generate its own self-excitatory impulse, another impulse from the SA node will reach the AV node before it starts its own self-excitatory impulse. So it actually overcome the excitatory rates of all other self-excitatory nodes or fibers. Okay. So that is actually the reason why it is the pacemaker of the heart, and that's in the normal situation. But sometimes in abnormal situations, if something wrong with the atrial sinus node and it cannot generate an action potential, then the AV node or the Purkinje fiber may have or generate the action potential, and that will affect actually the heart rate. It will make it respond to the rate of their self-excitatory or discharge rate. So, and that condition we call ectopic pacemakers. So any pacemaker that can make a pace of the heart, that can generate the action potential or impulses other than the SA node, we call that an ectopic pacemaker. So other than the SA node, it could be in the AV node or in the Purkinje fibers. So if something wrong with the SA node, then the AV node or the Purkinje will start or initiate their own rhythm for the heart. Sometimes the reason for having an ectopic pacemaker is having an AV block. The impulse is not able to be transmitted from the SA node into the ventricle. So this condition is called AV block. So then the atrium will have its own rhythm, which is related or referred to the SA node, but the ventricle will obey another rhythm, which is in the either in the AV or in the Purkinje system, in the AV bundle or the Purkinje system. Could be the penetrating AV bundle. So, and that is a syndrome which is called the Stokes-Adams syndrome. So once the AV block happens, there will be a time of about 20 to 30 seconds of no contraction in the ventricles because of the block, until the maybe the Purkinje fibers are able to initiate their own rhythm, because usually they are in a state of inactive state until a time lapse of 20 to 30, and in this time lapse there will be no contraction in the ventricle, and then until the Purkinje fibers are able to start their rhythm and start conducting, and then there will be again a heartbeat of lower rate, actually lower rate than before, and it's actually a very serious condition. It can be fatal. The rule of a Purkinje system. The Purkinje system, as we discussed before, the conduction in the Purkinje system happens too fast, okay, and that's allow the whole ventricle to be depolarized instantaneously, and that will make the contraction happens nearly at the same time. Due to the fast conduction, and that's very important for the force of the heart. Okay, if it wasn't fast, not all the ventricles, the places in the ventricles will contract at the same time, and that will affect the efficiency of the heart pumping. It will be less efficient, maybe up to 20 or 30% less efficient than having them fast and have fast conduction. Now, there is an important control over the function of the cardiac, autorhythmic, and conductive system, which is the autonomic nervous system by the parasympathetic and the sympathetic nervous system. What is the role of parasympathetic in the control of cardiac rhythm and conductivity and contractility? The parasympathetic innervation, we know, for the heart is via the vagus nerve, and actually as we know that the supply by the vagus nerve is performed or is actually mainly to the SA node and AV node, okay, rather than the ventricular walls. So any parasympathetic or vagal stimulation will actually affect the cardiac rhythm as well as the conduction between the atrium and the ventricle. So what happens is that when the parasympathetic is stimulated, it will release acetylcholine, the neurotransmitter, the main neurotransmitter for the parasympathetic system, and this hormone has two major effects on the heart. The first effect, it decreases the rhythm, the rate of rhythm of the SA node, okay, and the second effect, it will decrease the excitability of the AV junctional fibers, or the as we know in the AV node and the AV bundle, okay. So that actually will slower the transmission between the atrium and between the ventricles. So the ventricles, the cardiac impulse reaching to the ventricles will be slower, will be transmitted in a slower pattern. The mechanism by which the parasympathetic stimulation decreases the excitability of the SA node as well as the conduction is that the release of acetylcholine induces changes in the permeability in the membranes, which will cause it less leaky, okay, to sodium, calcium, and more leaky to potassium. And that will induce a state of hyperpolarization. And as we know, hyperpolarization, which means that we move from, instead of minus 55, we'll have minus 65 or even minus 75. So that will make the membranes of the fibers less excitable. So it's harder to reach the threshold potential to make an excitation. So if we are talking about the SA node itself, the self-excitation will be harder, and it will be harder to cause an excitation because the membrane potential is very negative. So this will slow the rate of rhythmicity or autorhythmicity of these nodal fibers. And sometimes if it's really strong, it can stop the rhythmical self-excitation. So it will stop the rhythmical self-excitation of the node. So we might have a skip in the beats. If we are looking at the AV node, what are the effects of the parasympathetic stimulation on the AV node? In the AV node, the hyperpolarization will make it difficult to conduct or to make or generate electricity or impulse to excite the nodal fibers. So the small atrial fibers that should conduct the impulse from the SA node will have difficult time to generate enough electricity in order to excite the fibers in the AV node, the nodal fibers. Okay, so that will make a further delay in the conduction. Okay, a delay that is even more than the normal delay. If the parasympathetic stimulation was moderate, this delay will be only prolonged. Okay, so the conduction will be prolonged. But if there were a large or stronger parasympathetic stimulation, this might block the conduction entirely, might have a heart block. This will block the impulses from passing into the ventricles. The other part of the autonomic nervous system control is the sympathetic nervous system control. And as we know, the sympathetic stimulation releases the norepinephrine, and the main effects is to increase the cardiac rhythm, so it affects the heart rate, because we know that the supply of the sympathetic nerve endings are actually distributed to the SA node, AV node, as well as the whole conductive system and the whole ventricular muscles. So the effects will be to increase the sinus nodal discharge rate. So the discharge rate is going to be faster. And second, the conduction rate is going to be faster. Okay, and the level of excitability in all portions of the heart, even the whole muscles or kind of cardiac fibers, will also increase. And the third effect is that it increases the force of contraction. So as we talked before, the effect of the sympathetic system on the contraction is way more than the effect of parasympathetic on contraction. So the sympathetic affects contraction to a large extent, okay, in both the atrial and ventricular muscles. Sometimes the maximal stimulation of the sympathetic can triple the heartbeat. We can get triple the heartbeat beat frequency, and as we mentioned before, it could reach 200, 300 beat per minute. Okay, and also it can increase the strength of contractions to double, okay, to twofold. The mechanism of the sympathetic control, as we said before, the neurotransmitter released is norepinephrine, and norepinephrine stimulates the beta-1 adrenergic receptors that are distributed in the heart muscles, as well as in the cardiac muscle fibers, in the nodes, and in the conductive system. And this actually will increase the permeability of the to the fiber membrane to sodium and calcium, and that is the main point here. Increasing the permeability of the cardiac cells membrane to calcium and sodium will make them more easily or more excitable. Okay, so if we look at the SA node, this will cause a more positive resting membrane potential. Okay, so the resting membrane potential will be closer to the threshold, and that actually will make it will accelerate the self-excitatory capability of the SA node. Okay, why? Because it will increase the rate of upward drift or shift toward the threshold. Okay, in the if we look at the action potential of the SA node, this will be the rate of upward drifting will be faster, and it will reach the threshold faster, and this will accelerate the rate of self-excitation, and this will increase the heart rate, okay, as a result. And in the AV node and AV bundles, there will be an easier generation of action potential, okay, and conduction of action potential that is coming from the previous portion of the conductive system. So it will be easier to excite, each fiber will be easier to excite the next or the succeeding portion. And that actually will result in faster conduction in the AV node and the AV bundles. So the after the impulse is generated in the SA node, it will be transmitted faster than normal into the ventricles. The third point here is that calcium, okay, the increased permeability to calcium will increase calcium levels in the cardiac muscles, and that actually increases the contractile strength, because calcium is important for the contraction process between the myofibrils, and that will increase the contractility and the strength of contraction of the cardiac muscle in the atrium, in both the atrium and also in the ventricles. And increasing the force of contraction will actually increase the cardiac output, okay, and that will increase the supply for our body. And that's actually the main point, or the importance of sympathetic stimulation, which is to increase the cardiac output, okay, to supply the body with increasing demands, okay, اللي في حالة الfight or flight.